Welcome to the ACE Behind the Scenes podcast, giving you an exclusive look at the creation of the popular continuing education program from the American Society of Anesthesiologists. ACE, testing your knowledge of the fundamentals of anesthesia.
Hello, this is Russ McAllister. I'm one of the editors of ACE, a product from the American Society of Anesthesiologists. And this is a behind-the-scenes podcast with other editors from ACE to discuss some topics. I'm the chair of anesthesiology at Baylor Scott & White Health in Temple, Texas, with the Texas A&M College of Medicine. I'm going to let the other editors introduce themselves.
Hi, this is Stacy Jones. I am an associate professor of anesthesiology at the University of Arkansas for Medical Sciences here in Little Rock. And Joel Johnson and I are the co-editors-in-chief of the ACE product.
And this is Joel Johnson. I am a professor of anesthesiology at the University of Wisconsin in Madison, Wisconsin. Go Badgers. And I am a neuroanesthesiologist.
Hi, I'm Bhargavi Ghali. I'm an anesthesiologist and intensivist at the Mayo Clinic in Rochester, Minnesota. And I am one of the editorial board of ACE as well.
Excellent. Well, thank you all for joining us. I'd like to give the listeners just a little brief background on what ACE is. ACE was started many years ago as a product from the American Society of Anesthesiologists as a CME product to provide some education on general walking around knowledge in anesthesia. There are 100 questions per issue, and there's 2 issues per yearly subscription. And they're published in April and October. And you can get up to 60 AMA PRA Category 1 credits per year. And it's available in a print product, or you can use it on the web or as an application on your mobile devices. With this podcast, we're discussing items of interest in the ACE 18A issue, which will be launching in April. We usually start by talking about some items related to our own practices in some way. Stacy, you had mentioned some topics that you had entered for the 18A issues about your own practice. Can you share and tell us about one of the items from this issue?
Sure. Thank you, Russell. People ask all the time, how do questions get written in ACE? Do you assign certain topics to certain editors? And really, we've found that more interesting information comes out of things that the editors just write spontaneously. So we don't assign topics to people. Really, our recommendation is write about something that you've encountered, write about something you saw, and we find that this makes it a lot more interesting and maybe more applicable to our general readership. But one of my items is from a case I did last year, and it really kind of revolves around transcatheter ablation for AFib. You know, this has evolved quite a bit, and sort of as these procedures evolve, our understanding of the complications that can happen evolve as well. And early on, when I first started doing these, we worried a lot about atrioesophageal fistulas, and we saw this. And we monitored the temperature in the esophagus very carefully and told the proceduralist, the electrophysiologist what was going on, and if the temperature changed, they needed to know because they'd been burning for too long in one place. But also a complication of this procedure that we didn't really think about a lot early on was phrenic nerve injury. And you can tell from the image that, pulmonary vein isolation or burning the atrial tissue surrounding the ostium of each pulmonary vein is part of the procedure, and the phrenic nerve lies in pretty close proximity, proximal to the left atrium, and is at risk. And one of the things I've noticed they've been asking more frequently of us during this procedure, which we perform all of these AFib ablations with general anesthesia, is that we not use long-lasting neuromuscular blockade in these patients, because the proceduralist feels like if they are too close to the phrenic or stimulate the phrenic excessively, then the diaphragm will move. And so we were caught a little bit off guard when they said, well, the patient isn't paralyzed, are they? And we're like, seriously, what? You tell me now? But the complications, and there's a list in the item of the discussion of the complications of AFib ablation, and frankly, I think I've seen every one of them. So, again, reiterating, knowing what the procedure is and what the common intraoperative complications are allows us to provide better care.
That is great information, and I remember in our discussion on that question, I learned a lot because that's not a typical procedure that I participate in, but I think it's useful even for the non-cardiac anesthesiologist. So thank you for that information. Bhargavi, you also had an item that was based on your experience. Can you share that with us?
Yes. So I learned more about this topic when I was reviewing the patient chart in the morning. This patient had specifically asked to be seen in the preoperative clinic to discuss this specific issue. She was a CYP2D6-POR metabolizer and was very concerned about her anesthetic. And because I'd read this in her chart, I had to review it again before caring for this patient that day. And it was very important because of the fact that this can really make her respond differently to different opioids that we give to manage her pain in the operating room and postoperatively. And it made me realize the importance of tailoring the anesthetic to a specific patient. And the more we learn about pharmacogenomics, we realize that we're going to have to use this individual patient genetic information in tailoring anesthetics to each of our patients.
That is really interesting, and I think it also shows that our patients are coming in with more information than they used to, and that's good information to have. Joel, the first item in this latest edition is one of yours. Can you expound on that just a little bit?
Yeah, it's a pretty simple case, a couple of cases that I did in this past year, and both times I was called emergently to the operating room because the patient was desaturating. And both these patients had a mature tracheostomy. The interesting thing about this is that a lot of people don't really give consideration to the fact that the tracheostomy is pretty darn close to the carina, and that when you put an endotracheal tube into the tracheostomy, that the possibility of getting a right mainstem intubation is pretty high if you go much past about 7 centimeters. So this particular item allowed me to write not only about the cases themselves, but about the dimensions of the trachea and how long the trachea itself is, and where a endotracheal tube should be placed when it's put into a mature trachea. And just as Stacy had mentioned about illustrations, we have an illustrator that draws for us, and it also provided us a really nice illustration so that the whole piece comes together that way.
Yes, the drawings that she provides are really excellent and really bring the question to life. And that's great knowledge to have, and something that we don't necessarily always think about, but is always important to know. I've certainly seen that in my practice as well. I work at a training hospital, and it's very easy to get over-aggressive and insert that a little bit too far. So thanks for bringing that to light for us. Stacy, you wanted to talk about also another one of the items that you wrote having to do with cardiac anesthesia again.
Okay. This item that appears in 18A is mostly about the components of dynamic left ventricular outflow tract obstruction. And again, as perioperative echo becomes more commonplace, our understanding of the dynamic nature of some of these cardiac disorders just is expanded. And what we have found, and several fairly recently published studies have shown, that it's not just what we associate as our classic, obstructive, hypertrophic cardiomyopathy patient who has a big asymmetrical hypertrophy of their, basilar interventricular septum, and they're otherwise healthy and they're young and they have maybe a family history of sudden death. That this disorder really can affect a broader range of people, and more so than we probably appreciated in the past. we've seen now that there's a fairly high number of people who have systolic anterior motion of their mitral valve, where the anterior leaflet of the mitral gets pulled into the left ventricular outflow tract and contributes significantly to the obstruction. It's important to realize that, there's another group of patients who don't really necessarily have, asymmetrical septal hypertrophy who also develop dynamic left ventricular outflow tract obstruction in the presence of this systolic movement of the mitral. And there are a lot of factors that can precipitate that. Anemia, hypovolemia, inotrophic therapy, and there's a list of the characteristics that are associated with those patients. For example, a possible presentation would be a small, older woman with a long-standing history of hypertension, so the interventricular septum is hypertrophied, but she also has this systolic anterior motion of the mitral valve that causes the mitral anterior leaflet to obstruct the left ventricular outflow. They can present with all the signs and symptoms associated with systolic heart failure, but the treatment is very different, right? So things that mimic systolic heart failure, but on echo, you find that actually there's a small empty left ventricle that has a thick wall and a thick septum, and the mitral valve is obstructing the outflow. And that patient, who for all the world looked like that might have left ventricular heart failure, would be made worse by inotrophic therapy. So things that, would make the dynamic outflow tract obstruction worse would be things like tachycardia and increased contractility and hypovolemia. So I think this particular item is a pretty good review of all of that. And there are some not echo clips, but some pictures from actual transesophageal echo images that help illustrate the phenomenon.
Excellent. Thank you for that explanation. One of the things with ACE is we've got a very large audience of anesthesiologists that utilize ACE, so it's hard to tailor it completely to a single person. And so there's always a lot of questions that some may find difficult while others might find them easy. And what might be obscure to one person is commonplace to another. So we get a lot of comments from readers about questions that they found difficult. So I wanted to talk about some of the items in 18A that y'all think that some readers may find more difficult or obscure. Parvati, would you mind starting and just talking about one of the questions that you think fits that mold?
Sure. One of the questions in this edition is about postoperative neuropathies. And I think this is a really challenging topic for us as anesthesiologists. It's such a vague, broad topic, and there's so many factors that can contribute to postoperative neuropathies. And I know that often we struggle with the OR team in identifying the best way to position a patient. So this is really something that impacts not just us, but the entire intraoperative team. And understanding what risk factors patients have can help us figure out that we know that these patients are at higher risk and be more cautious about the way we position them. But the challenging thing about peripheral neuropathies is that you can even provide excellent positioning and people may still develop peripheral neuropathies. So the best things we can do is try to do the preventative measures that we know about, but this is a really challenging topic in practice on a daily basis, I think.
Yeah, that's excellent. Thank you. And that's a good reminder that even when you do everything right, sometimes things can still happen. Joel, you mentioned an item that you thought was more obscure for you. Can you comment on that?
Well, similar to the one that Bhargavi just talked about, this is written by Dr. Ha, and she is a expert in chronic and acute pain, and so that's an area that I tend not to spend a lot of time in. And in particular, this one was about a drug that I honestly had not heard about called naloxegol. It's an interesting drug in that it's a pegylated version of naloxone, and so it's meant to not cross the blood-brain barrier, and so that you can have an antagonist to an opioid and not have it get into the brain. But the question itself was about the fact that depending on what that patient might be taking in addition to the naloxegol, that they could have increased naloxegol concentrations and get themselves into some trouble because they will go into opioid withdrawal with those higher concentrations. So not only did I learn about a new drug, but also the fact, and we will probably go over that again and again in various editions, the fact that the drugs that everyone is taking do affect anesthetics, and sometimes those effects can be quite dramatic.
I'd like to just add to what Joel said at the beginning, in that ACE has never been designed to be a board prep, and the form of the questions are really not exactly what you would see on a high-stakes exam. They are intended to be a hook to get you to read the discussion, and hopefully reading the discussion will give you a better understanding of a topic or refresh in your mind something that you really knew but you can't remember or forgot. Because we do, like Joel said, we do get comments, and we read every single comment that our subscribers send back to us. Well, I want more of this type of, I want more cardiac, or there's too much cardiac, or I don't do peds, you shouldn't have peds in here. But again, the purpose of ACE from the time that it was started was to give standard knowledge across all areas of anesthesia. And there are some areas that get a little specific because we'd like to draw in some relatively new information or some change in a process of anesthesia that one of us has encountered that we may want to describe in more detail to some of our readers. So it's not a high-stakes exam. It's not that, but the discussions are, I think, and I'm just going to brag a little bit, I think far superior to what you'll find in most other CME products.
Yeah, I agree, Stacy, and that's a great point. And that's the reason that we have specialists on the editorial board for ACE, so that we can learn about these new drugs like naloxegol, because we're likely to see patients on that drug, and we need to be aware of it. So I appreciate that input. Stacy, you also wrote about an item. I know a lot of times we get questions from colleagues or our surgeons about certain specific things. There tend to be certain things that people ask about more often than others. I think you had one of those experiences. Can you share that with us?
Yeah, what do you do with the ICD? You know, this is sort of a recurring question all the time, and the clinical scenario in this item really kind of matches a patient that I actually had. And we started editing this, and someone said, "Oh, well, this is contrived." I'm like, "No, it's not. This came in to my room the other day." It's really hard. Rhythm management devices and the management of those in the perioperative period is tough. I predominantly do cardiac and thoracic, and it's still hard. I never have exactly the right answer. But there are a couple of things that always hold true. One is that if you place a magnet over an ICD, it will suspend the therapy, but it will not affect the pacemaker. The point that we were trying to drive home with this one is that if you have a patient who has an ICD but has a very high risk of electromagnetic interference, and in our case, that I tried to reflect in this item, they were operating right up next to the device, so the chances of the device sensing the electromagnetic interference was really high. And when we looked at the EKG the patient came with and then went back into her chart and looked at prior EKGs, it looked like she was pacemaker dependent. She had a spike before every single QRS going back for all the EKGs that we had on her. In that instance, you almost have to call the rep and have them reprogram the device. You know, you can get away, a lot of times you can get away with putting a magnet in a sterile sleeve and putting it in the field, or, other things you can do, but the points to drive home are that putting a magnet over an ICD will not affect the pacemaker function. And if the patient is dependent on that pacemaker and the device has a really high risk of sensing electromagnetic interference, you run the risk of having profound bradycardia or asystole. It's also important, this is a little bit of a sidebar, but to speak the same language as the rep so that you can get your information across quickly and convince them to come, because sometimes, the reps are hesitant to drop whatever they're doing and come turn somebody off if they show up, out of the blue like this. But we were able to say, look, we can't put a magnet in the field. They're going to be on top of the device. We think she's pacemaker dependent. And the rep came right away. So there are some instances where the right answer is to reprogram the device, and that's one of them. I think that's illustrated here.
We have that same line of questioning at our hospital as well. It's one of the most commonly encountered questions and concerns that leads to confusion. So thanks for commenting on that. Bhargavi, you also wrote an item about a drug that y'all don't typically stock in your OR. Can you expound on that a little bit?
Yes, this actually came up in discussion with one of my colleagues who had just recently been on call and had a trauma patient who was a chronic cocaine user and had used cocaine prior to coming in. And managing this patient in the OR required having some medications that we don't standardly stock. So treating tachycardia and hypertension intraoperatively, we have our routine drugs that we grab, the metoprolol, the labetalol. But for this particular patient, something like that would not be in her best interest. So having nicardipine was what was needed for this patient. And because it wasn't stocked in the operating room, it required some phone calls, someone going down to pharmacy to get it. But managing intraoperative hypertension and tachycardia in someone that chronically uses cocaine, we could cause some significant harm by using our routine medications. And it's really important that we keep this in mind, to not just grab the nearest thing when we're dealing with these situations. We have to think about the specific patient and their circumstances when we choose what medications we will use.
So one of the benefits of ACE is that it helps us keep up with what's going on with other specialties, and a lot of anesthesiology crosses over into different specialties where we have competing interests with surgeons and obstetricians, and we have to share knowledge with other specialties such as radiology and other things. Joel, you had a topic that you thought fit this role pretty well regarding ultrasound. Can you comment on that?
Yes, Russell. This goes along with the fact that we keep repeating here, and that anesthesia itself has a number of different specialties. And a question was written by Dan Kopaz, one of our former editors, who was interested in ultrasound artifacts. And this particular one was called a bayonet artifact. And the item goes through the physics of ultrasound and why it is that a needle that is placed in somebody's body can look like it's bent just from the fact that it is going through different kinds of tissue. The ultrasound waves are going through different kinds of tissue, and so it causes an aberration in what the needle actually looks like. There was an explanation about the density of tissue and how ultrasound flows through there that really was quite interesting, but really far afield from where I come from as a neuroanesthesiologist.
Excellent. Yes, I recall that question and our discussion about it as we were editing that question, and it was really interesting because I really learned a lot from that discussion. As Stacy mentioned, the discussion is really the meat of the ACE product, and getting to read and edit that discussion really taught me a lot about that particular phenomenon. So, Stacy, you also wrote an item that was kind of a different subspecialty from what you normally practice. Can you comment on that?
Yes, I can, Russell. Thank you. I'm laughing a little bit. I don't do much OB anymore. Just as an aside, my chair is an OB anesthesiologist. She has populated our department with some pretty serious experts in obstetrics, and we're the only high-risk OB facility in the state. So I just don't do much OB anymore. We have a lot of really highly trained obstetrical anesthesiologists. And I can never remember the side effects of all the different, like, uterotonics and tocolytics. And so this particular item that we're talking about just really lists some of the typical drugs we see to decrease uterine tone, stall preterm labor as much as we can until usually until they can get enough steroids in for lung maturity and deliver the patient. But all of these drugs have side effects that can affect the mother, and all these drugs can interact with other drugs that we give. So to me, it's a useful item for people who don't do OB. And what's the least likely of these drugs to cause this phenomenon? And I was sort of surprised and mildly horrified that essentially pulmonary edema can be caused by almost anything that we use as a uterotonic. And so the discussion, again, here just lists the commonly used classes of drugs and what the common side effects are. And then you're better armed to better take care of somebody if you need to, and you need to look at what drugs they're on and what potential side effects they could have. And that's really sort of what drove me to write this one.
And I think as ACE is designed for walking around knowledge, we may all at any given time be called on to take care of obstetrical patients. And it's always good to get a refresher course on some of those side effects so we can be on the lookout. And as I mentioned, ACE is established knowledge, and we write 100 questions per edition. And so sometimes we see topics that come up again, and they get repeated. And in that way, we get that refresher course on some of those topics. And some of those topics are just so important that it's worth seeing a similar question that touches on those same topics. Joel, do you have an example in this edition of some topic that we've maybe seen before that has shown up again?
Yes, this is knowledge that we all have, and at the same time that we all maybe aren't sure about. And this is the concept of stress dose steroids. Probably every other issue we have a stress dose steroid question, and the actual question changes perhaps, but the information that is presented is pretty much the same. And interestingly enough, it's always, well, we don't know if stress dose steroids really help. We go through the historical concept and what the literature says about the use of stress dose steroids, but ultimately we come up pretty much with the same answer that it sometimes might help. We go ahead and give the steroids anyway, often, because we don't think that there is much risk other than a little bit of hyperglycemia, but we're not sure whether or not there's a difference or not. And we try to provide information that not only makes it clear when or if you should be giving a particular drug, but also tends to cast doubt on whether or not a practice is necessary or not.
Interesting. Yes, I agree. And conversely, we also, with ACE, we try to write questions that are going to be timeless and good forever, but we can all think back to questions that we took on our board exams that are obsolete now. And so we try to avoid those, but it's still good information. But I think sometimes we find some of the topics and that we're editing, and we look at them and say, this question may not be relevant 5 years from now or 10 years from now. And so we see that occasionally. Bhargavi, can you comment on any question from this edition that you think may fit into that category of questions that we may look back on and see the historical significance, but may not be useful in our future practice as our specialty changes?
There is a question that I think is something that we don't see as much, and as time goes on, we'll be likely to see it less and less, and that's catheter-induced pulmonary artery rupture. Clearly, it's still a devastating complication, and we need to know about it, but I think some of our more junior colleagues are less likely to see this, as we tend to use fewer and fewer pulmonary artery catheters. We used to use them very frequently in the operating room, and even now, cases that we were routinely placing pulmonary artery catheters for, such as liver transplants, have been moving away from routine use of pulmonary artery catheters. Cardiac cases continue to be the cases we use them most for, but even in some CABGs in patients who have normal cardiac function, They are performed without placement of a pulmonary artery catheter because we have access to TEE in the operating room, and this can help us manage them during their unstable points in the surgery, and it may not be necessary to have the pulmonary artery catheter afterwards. Additionally, we have newer and newer non-invasive dynamic monitors that use arterial pressure waveform analysis to help us calculate values that we had previously used pulmonary artery catheters for routinely. And this has helped us get away from the invasive monitoring that we do with the pulmonary artery catheter.
Excellent. That's a great analysis of that. At our institution, we don't use them nearly as frequently as we did when I was in training. So sometimes questions can have an impact on our practice and change the way that we do things. And I've seen that with some of the information I've learned through ACE over the past few years. Joel, I was wondering if you might share your story that we talked about a question that changed the way that you practice.
It really was not only the question that we wrote, but also following up with that, a publication that appeared in Anesthesiology a little bit later on. But one of our former editors, Dr. Liu, had written a question about how to improve a patient's perception of a physician during a preoperative visit, and that kind of foreshadowed a publication in Anesthesiology that looked at posture and gender during physician interviews, and it really started me thinking about, well, how do I conduct a preoperative interview, and how does that perhaps affect a patient and their sense of the person who is actually going to be taking over their physiology. So what it did for me is that it started to make me think, well, I need to sit down in front of this patient while I'm talking to them in the preoperative area. This particular one of these publications talked about how you need to have an open stance. And then it talked about the perception of a physician, as I mentioned, based on gender or on age. And all of these things we need to be considerate of when we're talking to patients, because ultimately they're trusting us. They are looking to us to hopefully calm their fears. And what I found particularly important is to give the patient a chance to actually voice those fears or ask them, how are you feeling today? Whereas what usually happens in the preoperative interview is that we are just gathering information. So I found this really valuable, and ACE started that.
One of the things that I added to my preoperative discussion that I learned from one of my orthopedic surgeons is, after I'm done with the discussion, at the end, I just say, is there anything that I have not asked about that you feel like it is important for me to know? And I think that's a really good open-ended question that allows them the opportunity to share something that might be very valuable. And since I've been doing that, I've had a couple of instances where they've opened up and shared something that I did not know, and it proved very helpful during their surgical care. So I appreciate that, and I totally agree with you. Stacy, you had another topic that you wanted to comment on. Do you mind sharing that with us?
One of the items that I wrote for this next volume focuses on perioperative atrial fibrillation. You know, we know a lot about post-op atrial fibrillation in association with cardiac and thoracic surgery, but last year the journal Anesthesiology ran a wonderful review article looking at risk factors for post-op AFib in patients who were not having cardiac surgery. As you might expect, some of the same badness applies, right? Post-op AFib is associated with, increased length of stay, increased morbidity for sure, and they really looked at what are your risk factors. And so I found that to be very helpful. It was a very well-written article and really helpful, because we do see post-op AFib sometimes in the recovery room in a patient that really had given us no indication that they had this as a problem or a pre-existing problem. And what are the things we should look for? And it only touched briefly on treatment, but mostly what are the things you need to be looking for and what are the risk factors?
Yes, that's an excellent point. And one of the things that we see at our hospital as well is postoperative atrial fibrillation, and it's always challenging, and we want to make sure that we're doing the right thing for them. So a lot of times with ACE, we edit each other's questions before we get together as a group. So we get to know the questions written by others fairly well. Bhargavi, you had a question of Joel's that you said you wanted to discuss.
Yes, Joel had written a question about a trauma patient who may have an unstable C-spine and use of video laryngoscopy versus direct laryngoscopy. And when I was reviewing his question, it made me realize that we make a lot of assumptions about advances in technology in anesthesia and just assume that because we have advances such as video laryngoscopy, that they are superior in many ways in multiple circumstances. And Joel's question focused on not only just the visualization, but also the concerns about possibly moving the C-spine and increasing risks with that maneuver. What I found really interesting is that there isn't evidence that the video laryngoscopy is better than direct laryngoscopy for certain parts of managing a patient with an unstable C-spine. And this was really interesting, and it made me really think that we need to think about the assumptions we make when we have new devices or just embrace their use in every situation.
So we probably have time for just one more item. Joel, you had one item that you were talking about ambulatory surgery centers. Can you comment on that?
Sure, and I would just as well open this up to the rest of the group as to whether or not they have any comments about this. This is an item written by Rick Dutton. What it dealt with is guidelines for ambulatory surgery centers, and this is kind of a soft topic because everybody's ambulatory surgery center may have a little bit different guidelines, but we have to keep in mind the fact that there are guidelines and there are also policies and standards and all these different words that we use. And really a guideline is something that is suggested. And so what we do with most of these kinds of questions is we go ahead and designate and cite a particular authority, for instance, the ASA guidelines on ambulatory surgery centers, in order to make it so that our item and the question that's being asked, that there is a correct answer and incorrect answers. But the fact is that they may vary between different ASCs. And in particular, we were talking about whether or not someone is required to be present, for instance, after a patient is discharged from an ASC. Do they have to be present just for driving them home? Do they have to be present for 24 hours or 12 hours after they are home? The ASA doesn't specify some of those exact things. They don't specify age, for instance. They don't specify a weight limit for their patients coming in to have surgical procedures. But sometimes different ASCs will specify what their guidelines are, what their rules are for patients. And I just find that fascinating that we, number one, can't decide sort of nationally on what is a requirement for an ASC, but at the same time, it does give everybody a lot of leeway. Anybody else have any comments about that?
Joel, I'm going to jump in with this real quick. The legal department at my place, which is not an ambulatory surgery center, but a major hospital, has ruled that some of these guidelines place restrictions on our patients that may actually be infringements of their autonomy. So we allow people to take Uber or whatever transportation they can find home, and we don't necessarily require someone for 24 hours. They need to be accompanied by a responsible individual, because we had issue where we wouldn't discharge someone in the care of their 17-year-old, even though there was an adult family member at home, but the 17-year-old was to take them home, and that didn't meet the criteria for adult. So our processes are a little different than even what the ASA recommends, kind of based on what our patient population is and how our legal department interprets these guidelines.
Thanks, Stacy. Yeah, I'm going to jump in as well. With the COVID pandemic over the last year, I think it's getting harder and harder for a lot of people to find that ride home, especially those who don't have living family that are near them. It's a bigger ask now than it used to be to ask a friend to give you a ride home with the COVID crisis. So we've run into that same problem in our institution. So it's best if you know it ahead of time as opposed to getting it sprung on you afterwards or the day of surgery, so that you can make some adjustments in your schedule and possibly schedule them earlier, allow them a little more recovery time so that you can deal with those issues during the daylight hours. But that is an interesting phenomenon, so I appreciate that.
And Russell, speaking of COVID, I sort of think of 18A as being our COVID issue. I'd like to give a shout out to our managing editor, Ginger Clark, and to all of our editors who have continued to write and to edit really during a point in time when all of our lives have been disrupted. It's been a little harder because we have not been able to meet in person, and all of us have been asked to do things maybe other than just give anesthesia and to respond to this crisis. But we've still been able to write really outstanding items for this volume. And Jennifer Kincaid, our medical illustrator, has created a beautiful cover art. So I think everybody will be entranced by that. And her illustrations and the ones we've been able to put into our discussions, I think, really add to the value of the product.
That's an excellent observation, Stacy, and I agree with you. It's been a very different experience as a member of the ACE editorial board. I believe that the in-person experience of editing these questions has a lot of value where we can bounce ideas off of each other. It's harder to do that over a Zoom call, but we struggled through it and got it done, and lots of credit to Joel and Stacy as the co-chiefs getting it accomplished, and as you said, to Ginger for keeping us all on track. So, well, thank you to all of you. I think we're about out of time. I appreciate everyone's input. This has been a very productive podcast, and the 18A issue of ACE launches in April, and you can order that now at asahq.org/ACE. So asaheadquarters.org/ACE. And I hope that everyone gains a lot of beneficial knowledge out of it. We had a great time putting it together, and I look forward to our next edition and our next podcast. So thank you all.
Bye, everyone.
Bye. Thanks.
Thank you for listening to the ACE Behind the Scenes podcast. For more information or to subscribe to the ACE program, visit asahq.org/ACE.